Thank you. These are my disclosures. So we know that women represent over half of people living with HIV worldwide. And in my corner of the world, we know that the highest rates for women in new diagnosis are in the 30 to 39 age group. We also know that 21% of the new HIV diagnoses in Europe are among people over 50 years old. And we know from UNAIDS data seen on the right that people are aging with HIV. So it is very important to diagnose and manage menopause because it's something that is going to affect women living with HIV for years and years, and it's going to affect their quality of life. What's the diagnosis tool we use? The WHO definition, which is 12 months of amenorrhea, non-related to any intervention or not due to any other medical reason. And this is the most widely used, but some people use STRO plus 10 criteria, which add also hormonal markers and presence of symptoms. Symptoms are varied and can affect every aspect of women's lives, but largely fall into these categories: vasomotor, urogenital, mental health, sexual and cognitive function issues, and bone and muscle symptoms. And there are different scales and questionnaires to assess the presence and severity of the symptoms, menopause rating scale being one of the most widely used. But I have to say that none of these tools have been validated specifically for women living with HIV. And we also need to be very careful about diagnosis overlap. We need to think about menopause in many cases. A good example is menopause and depression, because you see here that in the menopause rating scale, we have many questions about depressive mood, sleep problems, and anxiety. And on the screening questions proposed for depression, we also have many questions about symptoms related to menopause. So we need to think about menopause, and we need to think about its effects, long-term effects in cardiovascular risk and metabolic parameters, mental health and bone health. And we know that most of these comorbidities are more prevalent in people living with HIV, either because of lifestyle or chronic inflammation or ART effects in some cases. So the question is menopause different for women living with HIV? In this very good review signed by my friend Nekano Kolo, some studies suggest menopause appears in women living with HIV 2 to 3 years earlier, but others do not see any difference. And maybe this is because there are many confounding factors related mostly with lifestyle and substance use. But we have some data showing that women living with HIV have higher incidence and severity of symptoms. And in the pathophysiological level, what happens when we lose estrogen function? Because estrogen seems to interact in various ways with almost all cells of the immune system. Well, the answer is it doesn't seem to affect profoundly. So we don't have any data that there is a change in CD4 count or viral loads or response to ART. There's no indication to prefer one type of ART over another unless we want to avoid drug-drug interactions. Having said that, we need to say that we don't have many data on ART and women living with HIV. Historically, they represented a very small percentage of recruitment in pharmacological studies. And how do you manage the situation? Well, the standard therapy, it's hormone replacement therapy. I'm not going to go into detail because I know you're going to hear about that. But I have to say that the uptake is very low among women living with HIV. The indications and forms of treatment are the same. The indications are just these two: symptom control and osteoporosis prevention. We recently got an approval for the first non-hormonal medication for vasomotor symptoms. And I have to say there are no published data on the effect of HRT on menopausal symptoms in women living with HIV. So the guidelines in Europe, they are clear. We need to screen women over 40 and offer them HRT if they want to take it. And how about the effect of HRT in bone health? I think this is an interesting study from last year. Women living with HIV were compared to a control group, and there was no difference in the osteoporotic fracture risk. But funnily enough, women living with HIV received twice as often HRT, which is usually not the case. So we need more studies like that with longer follow-up periods and larger numbers in order to reach a conclusion. And this is another interesting study about HRT effects on cardiovascular risk. We see that this study assessed subclinical atheromatosis, and the conclusion is that women who ever used HRT had 43% lower prevalence in carotid plaque formation, and the findings were similar in women with HIV and those without. So it seems that HRT may confer a clinical cardiovascular benefit in women with HIV, and we need to look into that in larger studies. Very quick note that we need to look into drug-drug interactions and avoid protease inhibitors, cobicistat, some NNRTIs. And we also need to consider long-term risks for thrombosis and breast cancer. We have newer forms of HRT with minimized risk for these. Historically, people with HIV had increased risk for thrombosis, but recent data suggests that if somebody is virally suppressed on ART, the risk for thrombosis is not increased. And women with HIV have the same risk for breast cancer, which is basically dependent on the type of progestogen and the duration of its use. This is a very good review that was published by our group recently, a few weeks ago, so you can find all the information. But I also wanted to show you this other publication. It's also a recent publication from this summer. We did a survey in European healthcare professionals, and we asked them how they manage menopause. So they do regular screens for comorbidities related to menopause, but less than 70 and less than 60% ask for menstrual patterns and menopausal symptoms in women in the menopause age bracket. And what was striking for us was that 44% stated they were not confident assessing menopausal status and or symptoms. So it seems that we need to train healthcare professionals on menopause. And to conclude, what we don't know and what we're not doing well at the moment is this. In terms of screening, we don't know what's the best clinical scale or tool is for women living with HIV. Our group is currently looking into that. And we need to make sure that we ask women over 40 for mental and sexual health, as well as menstrual patterns and menopause symptoms. And in terms of management, we need more data and specific data on HRT effects, on symptoms, on long-term health effects, and on possible problems related to the HRT. Most of all, we need to remember to ask the woman, ask about their symptoms, what they want, and what they wish for. So thank you very much.